Brendan, just tell me, I remember you coming back and saying, I don't want to start doing ICLs until I can use Guru. When we first introduced it into the clinic, we try to have all our nurses and techs learn it. And we figured out early on, there might be 2 or 3 who could do it. But then things changed, and you've had it done about 10 times yourself. Take us through how we introduced it into the clinic, how we got to the point where every tech can do it, and how it works now.
When we first got it, Enrique Pfeiffer came over and trained 2 of our most senior nurses. And he gave them hands-on training with our clinic manager as a model patient, and I was a model patient as well. And initially, the first 1 or 2 cases that they did, because our nurses are really detail-driven and quality-driven, the scans probably took 20 to 30 minutes to do before they were really comfortable. But that's getting used to holding the device. These were cases where they were doing it unsupervised because Enrique had left and they were responsible for the data themselves. They were being very careful. But I would say within, honestly, 2 weeks, it was down to 10 minutes for both eyes. And so we had Sophie and Tara doing it. But they started to enjoy it so much, it almost became one of their favorite sessions was to do the UBM session. They really enjoy the kind of practical, procedural nature of it. And I think walking a patient through an experience like that is a way for them to express their kind of nursing ability, their caring and their guiding. So they started to really enjoy it. And then the other techs wanted to get involved as well. There have been 2 sessions where our nurses that are most experienced have trained the other 6. So they did them in 2 sessions, 3 new techs per session. I've had at least, the 2 eyes combined, I had about 15 UBMs done. And I think the updates that the Sonomed have made it easier to get higher quality scans quicker. The guidance, the color-coded guidance. But now they can all do it. I suppose the thing that, from a workflow point of view, is so powerful is that the ICL Guru software is integrated with the UBM. So they do it, and 2 minutes later, we've got the ICL Guru printout, and we can tell the patient that they're suitable or not for those borderline cases. Obviously, the way we do things is we want every case to be done to the highest standard. We're not only doing the UBM for very straightforward cases where we know we get an acceptable volt with any sizing methodology. We want the best ICL size for every case we do, whether or not it's a slam dunk one or whether it's a borderline one. But for those borderline ones, the patient knows on the day. They have their Sonomed and we tell them on the day whether you're suitable or you're not suitable or how suitable you are. If we can do same day bilateral under a GA or if we want to separate them, you just do one at a time. And then that's hugely powerful. The fact that we get such quick turnaround, it's so integrated. There aren't many extra steps for them to do the sizing calculations.
Brendan, I've heard a number of patients say, and I've heard the techs say, and I'll ask you as a patient who's been through it, is we did some of our cases with sedation, we do some other cases under general anesthetic, but we do the massive majority, 90% under topical. And that the nurses and techs are almost guiding us as to what the patient's going to be suitable for. So they're saying if the patient can have the Guru done and they're comfortable, then they're going to be comfortable with topical. How does that flow?
There were a couple of things. When I had my first UBM done to me, it was quite a jolting experience just because the water was so cold. Now we warm up the water before we do the water bath, and the last year I've been much more comfortable. But it's the only thing you can feel is really the temperature. And once the nurse gets the hang of how much pressure to put on, it's quite comfortable. I think from a patient point of view, it's the first time you've been lying down trying to be still. Sometimes that's a bit more nerve-wracking. I suppose also they still have that anxiety of, am I going to be suitable for this procedure? And their hopes are riding on the scan as well. If they've gotten through the UBM comfortably, then we know they'll be fine for the topical surgery, because the topical surgery is probably going to be a similar amount of time and they're not under a water bath. The water bath's the only thing that's a bit strange about it. Whereas if somebody's really finding the UBM difficult, then there's no point in putting them through a stressful surgery. If they're asleep, it's more comfortable for everybody. So that's a big advantage of doing this screening, because previously I can imagine we may have had some patients on topical where it's been more difficult than we anticipated, even if the patient seemed so relaxed in the consultation. Just when they have a speculum and suddenly everything changes.
That's the exact point I wanted to make. You've made it very nicely, is that besides giving us the best information on the sizing and predicting what we're going to get in terms of volt and angle, it's been an amazing tool to guide us into which way. And the truth is, we're doing many more cases now under topical than we ever did before, because they're finding Guru overwhelmingly positive and nothing to it. They expect worse. And then we say to them, the surgery is pretty similar. And they decide to go with topical rather than anesthesia.
Yeah, the other big change is we've been doing same-day bilateral for the last, probably 6 months or so, maybe a bit more. Topical, where we can do an OCT between the two eyes. But now if I see a Guru printout where there's a really big safety margin, I'm very happy to do same-day bilateral under DA. So immediately sequential.
I've done it a few times.
With the experience we've got with Guru, we know that it's going to be there or thereabouts. And if there's a good safety margin, there's no kind of hesitation in proceeding to the second eye before checking the volt. It's been so accurate so far.
Yeah, absolutely.
I think we've had 86% of our cases within 200 microns of the predicted volt.
86% within 200 microns.
Yeah. If you think the average eye take a volt between 50 and 800, that's a huge safety buffer on either side.
I think almost as important is that there have been no patients with very low volts and no patients with very high volts.
Yeah, exactly. So
more importantly, there have been no patients with angles that are threatening to occlude. They've been occluded. I'm almost more interested at this stage of my career in the angle, the predicted angle, than the volt, because the volt with a little aquaport, I think, is quite forgiving, but the angle accuracy, the predictability of that is such a useful tool.
If the volt is high, the surgeon feels maybe that could look better on our OCT and the patient's happy. But if the angle is low, you better remove the lens. There's a hard stop there. Avoiding a narrow angle is the only thing that is really a fixed thing that you have to avoid.
If you think about a patient where there are two lenses you can use, two sizes, but the lens is toric. If it's non-toric, it doesn't matter which lens you choose probably. But if it's a toric lens, you really want to use the bigger one to get a bit more of a fixation. But then you want to know, what does it suggest or predict the angle is going to be? And the level of confidence is just completely different to what we've ever had before.
That's just actually a really good point that I hadn't really thought of before, is we've always said this ICL Guru and the Sonomate UBM aren't likely to improve our visual outcomes. It's likely to improve our safety and confidence. But I think when we look in a few years' time, if we look back at our toric outcomes, they're going to be a lot more stable because we're choosing the lens that has the greatest rotational stability. It's not just based on what's the one lens that's going to fit. For many patients, there are 2 or 3 lenses that could fit, and we choose the one that is the lowest likelihood of rotating.
Exactly. And the latest version of ICL Guru, in fact, has an indicator of the rotational stability.
That's something that we should look at.